and welcome. My name is Dr. David Lewis. I'm the Ultrasound Program and Point-of-Care Ultrasound Fellowship Director at Dalhousie Department of Emergency Medicine, St. John, New Brunswick, Canada. Ultrasound is a high-frequency sound wave. Waves are described in physics by their amplitude and their wavelength. The greater the amplitude, the higher the volume, and the shorter the wavelength, the higher the frequency. As a sound wave passes through a medium, particles within that medium are either compressed or rarefied. This cycle of compression and rarefaction results in a typical waveform appearance. The frequency of the sound wave is measured in cycles per second. Audible sound has a frequency of between 20 Hz and 20 kHz. Middle C has a frequency of 261 Hz. The next frequencies you will hear are getting progressively higher. At some point, depending on your age, you will be unable to hear them. For those who heard it, the last tone played was 18,000 Hz. Ultrasound is measured in megahertz. The frequencies are therefore 1,000 times higher than audible sound. This is a graphical representation of an ultrasound transducer. Within the transducer head are hundreds of piezoelectric crystals. When stimulated by an electric current, these crystals vibrate and generate a sound impulse. The transducer spends 1 millisecond generating the pulse of sound and 999 milliseconds listening for the returning echoes. The returning echoes vibrate the piezoelectric crystals, which results in a current generated and can be interpreted by the machine. The transducer is therefore generating the ultrasound wave and listening for the returning echoes. Point-of-care ultrasound image generation. The transducer generates a sound wave. This sound wave passes through tissue, reflecting off structures. These echoes return to the transducer. These echoes are then interpreted by a computer within the machine, and an image is generated. As the sound wave passes through tissue, echoes are reflected from structures at different depths. The time taken for these echoes to return to the transducer is measured. A structure whose echo returns quickly is placed superficially on the screen. Echoes that take longer to return are placed deeper on the screen. The brightness of the structure depicted on the screen is determined by the reflectivity and amplitude of the returning echo. Highly reflective structures generate an increased amplitude of the returning echo, and this is depicted as brighter on the screen. All the returning echoes across the entire sector are placed on the screen in relation to depth and brightness. This initial image just has a few returning echoes. The next image has thousands of returning echoes. And finally, we can see a recognizable image being generated. Next time you're using PoCUS, remember that the depth and brightness of each pixel on the screen is determined by the time and reflectivity of the returning echo. In this image we can see some free fluid at the caudal tip of the liver. Fluid has very low reflectivity, and therefore the returning echoes are dark. The image depicted on the screen is therefore made up of pixels whose brightness is determined by the reflectivity of the underlying structure. Reflectivity is otherwise known as echogenicity. Structures with high reflectivity or echogenicity are white on ultrasound. These include bone, calcium, stones, and dense fibrous tissue. Structures with very low reflectivity or echogenicity are black on ultrasound. This includes blood, urine, bile, and other fluids. In between these two extremes are the other structures of the body, including liver, spleen, kidney, and muscle, all of which have varying degrees of medium echogenicity. This is a scan of the kidney with hydronephrosis. I'm using this image to introduce the common terminology used when describing a structure's appearance on ultrasound. The normal renal cortex is relatively hypoechoic. The renal sinus is relatively hyperechoic. The renal pelvis is normally not visualized on ultrasound. In this case, with hydronephrosis, the renal pelvis is distended with urine. Urine, being a fluid, is anechoic on ultrasound. As sound waves travel through tissue, they lose energy. This concept is known as attenuation. When I talk to someone in a large room, the further apart we are, the quieter my voice will be heard. The sound waves generated by my voice are being attenuated over that distance. As sound waves travel through tissue in the body, attenuation is determined by the tissue impedance. Structures with high tissue impedance result in greater attenuation of the sound wave. Because of their shorter wavelength, high-frequency sound waves are reflected by more particles within the tissue. This results in loss of energy and attenuation. With their larger wavelength, low-frequency sound waves are less affected by tissue impedance. The loss of energy is less, and the sound waves are able to travel more deeply into the tissue. This concept is frequently experienced in other examples of sound waves and also radio waves. Low-frequency bass music played by your neighbor is much more intrusive than high-frequency classical music, even if played at the same volume. Depending on the angle of insonation, sound waves can also be refracted as they pass through tissue. This is due to a change in velocity of the sound wave as it passes from one medium to another. The greater the angle of insonation, the larger the degree of refraction. This can result in image artifact and can be minimized by trying to remain perpendicular to the structure of interest. When sound waves pass between mediums with significantly different impedance, reflectivity can become disordered and chaotic. This occurs when sound waves pass through tissue into air. The resulting randomly displaced reflections are known as scatter. The resulting image of the interface on the ultrasound screen is an irregular, brightly echogenic line and a deep, shimmering shadow known as a dirty shadow. In this clip, just deep to the liver, a loop of bowel can be seen. The bowel contains air. At the interface between the liver and the air-filled bowel, an irregular, brightly echogenic line is seen. Deep to this line, a dirty shadow is also visualized. Ultrasound transducers. Manufacturers produce many types of transducers. The common transducers, and the ones used in this course, include the curvilinear probe, the linear probe, the phased array. While the frequency of each transducer may vary by manufacturer, in general the curvilinear and phased array transducers are low frequency, and the linear transducers have a higher frequency. As covered earlier in the physics section, transducer frequency determines depth of penetration, but it also determines axial resolution. The higher the frequency of the transducer, the greater the resolution, but the smaller the depth of penetration. This also occurs with radio waves. High-frequency FM radio has a higher resolution than medium-wave radio. However, high-frequency FM radio does not travel as far out of the city as medium-wave radio does. Just as in radio, with point-of-care ultrasound, we have to sacrifice resolution when we need to achieve greater depth of penetration. The high-frequency linear transducer, shown in this image, is able to generate a high-resolution image at the expense of penetration. The maximum depth achieved for most linear transducers is between 6 and 8 centimeters, and is therefore mainly used when examining superficial structures. The curvilinear transducer has a lower resolution and is able therefore to penetrate more deeply. The maximum depth penetration available on most curvilinear transducers is approximately 30 to 35 centimeters. Expanding on the concept of ultrasound resolution, we need to understand that there are two types of resolution: axial resolution and lateral resolution. Axial resolution is the ability to separate structures parallel to the ultrasound beam, one below the other. This is dependent on the frequency of the ultrasound wave. Lateral resolution is dependent on the ability to separate structures next to each other. Lateral resolution changes with beam focus. Where the beam is focused, two closely neighboring structures will be seen as two separate structures. Where the beam is not focused, above and below, these neighboring structures may be seen as a single structure. The focal area of the beam can be controlled by many machines. In those machines where it can't be controlled, the focal zone is in the center of the screen. Adjusting the depth of the image will bring the structure of interest into the center of the screen and therefore within the focal zone. How to scan. Before you start scanning, preparation is important. Ensure the patient is positioned appropriately and comfortably. Raise or lower the bed height depending on whether you are sitting or standing. Ensure the machine is close enough to control and that the monitor is easily viewable. Pass the transducer cable under your arm to keep it out of the way. And most importantly, ensure that the lights in the room are dimmed. When most novice users first see an ultrasound machine, they see the many knobs, buttons, controls and display panels and immediately think, there's no way I can fly this machine. Don't worry, Much like a TV remote, there's really only a handful of buttons you need to know. The most important one being the on button. You'd be surprised sometimes how often the on button is not immediately apparent. Being unable to turn the machine on when you're with a patient does not instill confidence. The other frequently used buttons and knobs include one for patient info, the depth knob or slider, the gain knob or slider, and also the save function. Ensure you know the location of these functions before starting to scan. Before placing your transducer on the patient, consider which structure you want to visualize and whether there is an acoustic window available. Acoustic windows are tissues with low impedance, allowing easy transmission of sound waves. These include a full bladder, highly vascular organs such as the liver and the spleen, and also muscle. Try to avoid acoustic walls. Acoustic walls are tissues or viscous structures with high impedance. These include air, either external to the body or within hollow viscous, and also bone. Consider this image. The area of interest is the interface between the liver and the kidney. The acoustic window is the liver. However, a rib is centered in the field of view. The rib is an acoustic wall, casting an acoustic shadow across the area of interest. Moving the transducer between ribs ensures that the field of view has access to the liver acoustic window, and the acoustic shadows cast by the ribs do not obscure the view of the area of interest. Finally, assess this view. Are we utilizing an acoustic window or an acoustic wall? The transducer is placed over the stomach. The stomach is usually filled with air. Air is an acoustic wall. In order to visualize the aorta, we would need to slide the transducer medially to use the right lobe of the liver as an acoustic window. Anatomical planes and how to get orientated. The ultrasound transducer does not generate a beam. There is often some confusion amongst novice users that holding the transducer is like holding a torch, and that what is seen on the screen is the illuminated surface of the structures that we are pointing it at. In fact, the ultrasound transducer is generating a slice, just like a sword, or even a cake slice. This slice can be aligned with the anatomical planes, including longitudinal, coronal, and transverse. And here are the anatomical planes. The longitudinal plane, which when aligned with the midline is also known as the sagittal plane, the transverse plane, and finally the coronal plane. Orientation. Novice ultrasound users will rely heavily on orientation to generate standard images. As you become more experienced, orientation will become second nature. All transducers have an orientation marker on one side. The nature of this marker will change depending on the manufacturer. In the sagittal plane, the transducer orientation marker is orientated towards the head. In a standard setting, the screen orientation marker is normally situated in the top left corner. The left of the screen is therefore cephalid, and the right of the screen is caudal. In the coronal plane, the transducer orientation marker is also pointed towards the head. The left of the screen remains cephalid, and the right of the screen is also caudal. In the transverse plane, the transducer orientation marker is pointed towards the patient right. Monitor screen left is now patient right, and monitor screen right is now patient left. Probe handling. Standard terminology is used to describe the range of possible transducer movements. The transducer can be rocked to one side or the other. This is sometimes known as heel-toe. It can also be tilted, and this is sometimes known as fanning or sweeping. It can be rotated, and also you can slide the transducer in any direction. When considering directions, remember the anatomical terminology. Towards the head is cephalid or cranial, towards the feet is caudal, towards the midline is medial, and away from the midline is lateral, and finally there are anterior and posterior movements. Image optimization. Numerous factors contribute together in order to optimize the image. The image on the right is optimized, whereas the image on the left is not. Factors that can help optimize the image include the quality of the machine itself, operator factors including the use of depth, gain, and frequency. This is sometimes termed knobology. Operator factors of the transducer, including finding an acoustic window, avoiding air, and ensuring good contact of the transducer with the patient using lots of gel, otherwise known as goop. Finally, there are patient factors including patient body habitus, the patient's position, and the different views available during the respiratory cycle. Ultrasound artifacts. There are a number of false images caused by unique interactions between the sound wave and the structures in the body. These include shadowing, posterior enhancement, edge shadowing, reverberation, and mirror artifact. It is important to have a knowledge of these artifacts in order to distinguish them from real structures. Ultrasound artifacts can be extremely useful. Shadowing artifact is helpful to highlight small gallstones, and other artifacts are extremely useful in lung ultrasound. This image of the gallbladder demonstrates shadowing artifact. This artifact can be seen with any highly reflective structure. In this case it's a gallstone, but it is also seen with bone. Note that only the surface of the gallstone immediately beneath the transducer can be seen. The shadowing obscures the posterior wall of the gallstone. Posterior enhancement artifact occurs deep to a fluid-filled structure. The posterior wall of this renal cyst appears brightly echogenic. This is because the ultrasound waves that have passed through the renal cyst have been less attenuated than those that have passed on either side. These sound waves therefore have more energy and the reflections are brighter. Edge artifact is commonly seen when scanning circular or spherical structures. This is due to refraction from a curved reflector that causes the returning echoes to be weakened. Reverberation artifact normally occurs close to the transducer. This occurs due to a strongly reflective structure just deep to the transducer, and these reflections are then reflected back off the transducer into the tissue. This results in a closed-loop repeated reflection known as reverberation. And finally, mirror image artifact. This commonly occurs around the spleen and the liver close to the diaphragm. The diaphragm is strongly reflective. Echoes from the spleen or liver can be reflected back to the diaphragm at right angles. The ultrasound machine can sometimes incorrectly interpret these echoes as having originated immediately deep to the transducer. This can result in a mirror image appearance of a structure appearing to be both below and above the diaphragm. Talk about machine care. Infection prevention and control is extremely important. Ultrasound machines, in particular transducers, can easily act as a vector for fomites and be responsible for cross-contamination and transmission of infection. The transducer should be wiped down before use, and then after use it should be thoroughly cleaned, removing all debris and all gel, and then disinfected with a wipe. The machine, handles, knobs and buttons should also be thoroughly disinfected after each use. By doing this, we are following infection prevention and control standards, but also improving image quality and prolonging machine longevity. Always think of the next person using the machine. Make sure you leave it in a condition in which you would like to find it.